Chapter 17, Cardiovascular System, the Blood, Part 2. We finished talking about blood typing in the last part of this, Part 1, and now we're going to move on from red blood cells to white blood cells, which are also called leukocytes. These make up less than 1% of the total blood volume, and their range is about 5,000 to 10,000 white blood cells per microliter of blood. And their function is in defense against disease. They can leave the capillaries by a process known as diapedesis, and they move through tissue spaces by amoeboid motion and positive chemotaxis. So they move to areas where there is an injury or some type of a break in the skin or some type of inflammatory response, and they will attack any invaders that try to get in from the outside. Leukocytosis is an excessive production of white blood cells, and where the count is over 11,000 blood cells per cubic millimeter, and this is a normal response to infection. Now, there's two categories of white blood cells. There's cells that have granules in their cytoplasm, and these are called granulocytes. These have visible cytoplasmic granules, and there are three populations of granulocytes. They are called neutrophils, eosinophils, and basophils. The other two types of white blood cells are called agranulocytes because they don't have any visible cytoplasmic granules. And those are lymphocytes and monocytes. So actually, the white blood cells ending in phil are granulocytes, and the white blood cells ending in cyte are agranulocytes. So that's the way you can keep them straight. And in decreasing abundance in the blood, if you remember the sentence, never let monkeys eat bananas, that your most numerous is your neutrophil. Next is lymphocytes, monocytes, eosinophils, basophils. So this diagram, which shows you a breakout of the different populations of white blood cells, this gives you an idea of platelets, one of your formed elements, white blood cells, another formed element, erythrocytes, red blood cells, your third formed element. And if you expand your neutrophils, you will see that this is a differential red blood cell count. And your neutrophils make up around 50 to 70% of all of your white blood cells. Eosinophils make up about 2 to 4%. Basophils, sometimes you don't see any in a smear, but 0.5 to 1%. And your agranulocytes, lymphocytes, 25 to 45%, and monocytes, 3 to 8%. Here is a schematic that shows you the developmental pathway of leukocytes, and just like red blood cells, they start from this hematopoietic stem cell, also called the hemocytoblast, and then these will differentiate into two separate stem cells. One's called the myeloid stem cell, the other one is the lymphoid stem cell, and the lymphoid stem cell gives rise to your lymphocytes. And then your myeloid stem cell gives rise to all of your myeloblasts that eventually are going to become your phils with granules, your eosinophils, your basophils, your neutrophils, and then a separate population becomes your monocyte. And monocytes can leave the circulation and become your wandering macrophages and tissues. And I am going to save discussion of the B and T lymphocytes until the immune chapter, but these are involved with the cell-mediated type of immunity that we'll talk about in chapter 21. So just remember for right now that lymphocytes are a type of white blood cell. I'll tell you a little bit more about them, that if a person comes in and they have if they have some type of an infection, the main thing that they will do is they will draw labs for the hematology department, and they will do a white blood cell differential. Now, if you see an elevated number of lymphocytes, that generally tells you that it's a viral infection. If you see an elevated number of neutrophils, that generally will tell you it's a bacterial infection. So right away, by doing a hematology test right away on a patient, you can determine the course of treatment by determining whether it's a viral or bacterial infection. So you know whether to give antibiotics or not, because if it's not a bacterial infection, you don't give antibiotics. So again, elevation of neutrophils, bacterial infection, elevation in lymphocyte population means viral infection. So eosinophils. Eosinophils have a bilobe nucleus. They have red granules in their cytoplasm, and these granules are effective against parasitic infections. So parasites, protozoan infections like amoeboid dysentery, trichomonas, which is a vaginal infection. These are one-celled organisms, and eosinophils will increase in number during a parasitic infection. Also, they are effective against allergic reactions. So allergies, you'll see an elevation in this type of population. Basophils have granules. They have a bilobe to an S-shaped nucleus, and they have these large granules that contain histamine. Now, histamine will result in inflammation in tissues during an infection, and usually they go hand in hand with eosinophils. So eosinophils, allergic reactions, swollen mucous membranes, eosinophils, basophils, they usually see the populations rise together during an allergic reaction. So basophils release histamine. Histamine causes inflammation in sinus passageways, inflammation in other tissues. So when you have an allergic reaction, your bronchial passageways will produce a lot of mucus, may swell up. So that's from the histamine. So a lot of times if you have a sinus problem that's allergic or an allergy, you take antihistamine to block the effects of these histamines produced from the basophils. Neutrophils are called polys because they have a polylobe nucleus, and they can have 3 to 5 lobes in this unusual looking structure here. And they have granules too. And those granules will effectively put holes into bacteria. So they're proteins that can assemble, once these granules are released, assemble into the bacterial cell wall, open up a hole, and actually you're shooting the bacteria full of holes with these proteins contained in the granules. So those are neutrophils, or your bacteria slayers. Monocytes are like Pac-Man. They go around, they just eat stuff. And they have a kidney bean shaped nucleus, and they don't have granules, but many times you will see vacuoles in these, white vacuoles, and the vacuoles contain food that they brought in from the outside. So they break down stuff, they digest stuff, and they're just kind of your all-around garbage men is what I call them. And then lymphocytes, again, these two are agranulocytes, your monocytes and your lymphocytes. So they don't have granules, and the lymphocyte has a very large nucleus. Actually, it takes up almost all the volume of the cell. And many times when you see these, you don't see much cytoplasm at all. You'll see a little tiny ring of cytoplasm, and that's about it. So leukemia is a cancerous condition involving the overproduction of white blood cells. Myelocytic leukemia involves descendants of the myoblasts. So if you look back on that diagram, these are your eosinophils, your neutrophils, which I said are also called polys, and your basophils. Lymphocytic leukemia involves lymphocytes, so it's that pathway. Acute is quickly advancing if it originates from the blast-type cells. And if it originates in the earlier developmental pathways, you're not getting that many functional cells, and so this one tends to be very aggressive, tends to occur more often in children. Chronic types of leukemia tend to be slower advancing. The problem is in the latter stages of the developmental pathways, so you do have some functioning cells, and people can live a long time with this type of leukemia. And usually you see this in elderly people. But in all leukemias, you have immature white blood cells flooding into the bloodstream because you're not producing enough functional cells to shut off the negative feedback system. So you just produce a lot of immature white blood cells, And in exchange, you're probably not going to be producing enough red blood cells or platelets because you're too busy making the white blood cells that you can't make mature, healthy ones to satisfy the needs of the body. So that's leukemia. Mononucleosis is a highly contagious viral disease that's caused by the Epstein-Barr virus, and you get a high number of atypical agranulocytes. And these agranulocytes, because it's a virus, tends to be your lymphocyte population that increases in number during a viral infection. And when your lymphocytes become active, they stretch out and they start to become enlarged and they become very phagocytic. And their nucleus changes shape. And when they elongate and stretch out, it starts almost to look like a kidney bean. And because of that, when they first saw these atypical lymphocytes, they thought they looked like monocytes. And they weren't, they were actually lymphocytes, but that's where the term mononucleosis comes from, because the atypical lymphocytes look like they had a mononucleus. So there's mononucleosis. So the symptoms: tired, achy, chronic sore throat, low fever, and it could go on for months. Very difficult sometimes to eradicate in people. And you just have to rest. Platelets are cytoplasmic fragments of megakaryocytes. So megakaryocyte is the cell that they come from. And the megakaryocyte is huge. It's like about 150 micrometers in diameter, which is over 16 times the size of a red blood cell. And these cells cannot get through the sinusoids. They're too big. So while they're trying to squeeze through, they fragment into pieces, and those become your platelets. And the platelets are blue staining that outer region, so the actual cytoplasm area looks blue, and the granules look purple. And the granules contain things like serotonin, calcium, enzymes, ADP, platelet-derived growth factor, and all these things are really to cause the blood vessels that are injured to clamp down so it minimizes blood loss, and to aggregate more platelets and to seal off the break, the area that's broken. So a lot of these factors are platelet aggregating factors, things that cause vascular spasms, and also this thing right here, this PDGF, is kind of like the Miracle-Gro, because it helps to cause the repair process to happen and the walls of the broken blood vessel to come together and repair the break in that vessel. So all of these things act in the clotting process, and your normal count for platelets is 150,000 to 400,000 platelets, and that should be per microliter of blood. Here's your formation of platelets. There's your hematopoietic stem cell again, the hemocytoblast that all your blood cells come from. Start off with the megakaryocyte, and there's your megakaryocyte developing all the granules that are needed in the actual mature platelets. And there's your very large megakaryocyte fragmenting off into pieces that become platelets. And platelets only survive a few days in circulation. So the term hemostasis really means stopping the bleeding. And it's a fast series of reactions to cause the bleeding to stop. And it requires clotting factors, substances that are released by the platelets and injured tissues. But it occurs in 3 steps. And the 3 steps are vascular spasm, platelet plug formation, and coagulation, which literally means blood clotting. So vascular spasm is where you get vasoconstriction of the damaged blood vessels. So it kind of gets narrower to minimize bleeding. And the triggers for this vascular spasm are direct injury to vascular smooth muscle, chemicals released by endothelial cells and platelets, which we talked about, and pain reflexes will cause vasoconstriction. It's most effective in your smaller blood vessels. So platelet plug formation, the second part, is actually a positive feedback cycle, one of the few we have in the body, where the damaged endothelium, now the endothelium is the inner lining of the blood vessel. When that's damaged, collagen fibers are exposed. And those collagen fibers are something that the platelets will stick to, and they stick to it by way of this protein called von Willebrand's factor. And von Willebrand's factor is something that some people don't have. It's a type of hemophilia that doesn't involve one of the major clotting factors, which we'll talk about in a minute. But von Willebrand is something that allows the platelets to stick. And if you don't have this von Willebrand's factor, you may have trouble clotting. And I worked in the lab with somebody who was a carrier for it, and both of her children had it. And it wasn't something they had to worry about unless they were doing some type of surgery or some type of oral procedure that could promote a lot of bleeding. Then they would have to get the fresh frozen cryofactor of the von Willebrands preceding that surgery. So it's very interesting because I'd never heard about it before until I worked with her in the lab. So the platelets, they swell, they become spiked and sticky, and then they release their chemical messengers. The ADP causes more platelets to stick, so ADP is a platelet aggregating factor, and cause the platelets to release their contents, and this is what sets up the positive feedback cycle. And serotonin and thromboxane A2 enhance vascular spasms and platelet aggregation. It's mentioned later, but how aspirin works, aspirin binds up thromboxane A2 and can be used by people who are prone to strokes and producing blood clots. It can be used as a very simple type of daily regimen to help prevent formation of clots. So coagulation is the third part, and this is where you reinforce the platelet plug with fibrin threads, and the blood itself is transformed from a liquid to a gel. And it involves a series of reactions using clotting factors. These clotting factors are proteins, and they're procoagulants. They're numbered with Roman numerals 1 through 13. Most are plasma proteins, and vitamin K is needed to synthesize 4 of them, and these proteins are formed in the liver. So here's a recap looking at the steps involved in hemostasis. Step 1, vascular spasm. Smooth muscle contracts, causing vasoconstriction, so the blood vessel gets narrower or smaller in the middle. Platelet plug formation. Injury to lining of vessel exposes collagen fibers, and then the platelets are going to stick. And then the platelets release chemicals that make nearby platelets sticky, and you form this platelet plug. And then you get what's called coagulation, where the fibrin forms a mesh that traps red blood cells and platelets and forms the final clot. And there you can see your fibrin mesh forming right there. There's your platelet plug. There's your break. So this is the coagulation cascade. So there's two pathways, two separate pathways you see here. You see what's called the extrinsic pathway and what's called the intrinsic pathway. This one has a lot more steps. This one has fewer steps. And they converge on this part right here, okay? Now what I want you to know about the difference in the pathways, this one happens when you have a break in the skin and you injure tissue cells around a blood vessel. Those tissue cells release something called tissue factor or thromboplastin. And thromboplastin makes this pathway work very fast. You see there's not that many steps in between. So if you do a bleed time in the lab and you just make a little incision in somebody's skin and you wait to see how long it takes the blood takes to clot, usually takes about 6 minutes. Now, if you draw blood directly from a blood vessel, you don't have tissue factor because you're not damaging the tissues around. You're just going right into the vessels and drawing the blood out. And you're depending on platelet factor to make that pathway work. And platelet factor is from the platelets, and this takes a longer time to get motivated and get going. When you draw a tube of blood from somebody's arm, it usually takes about 20 to 25 minutes to coagulate. Here, only 3 to 6 minutes. And it's because of the presence of tissue factor. But eventually, both pathways converge on this factor 10 or Stewart's factor. And then Stewart's factor with some calcium, some platelet factor, factor 5. Eventually what you wind up with is prothrombin activator, okay? So the extrinsic and intrinsic pathway converge on factor 10, which is Stewart's factor, and then you get the generation of prothrombin activator. Now I want you to see too, Look at the calcium. A lot of calcium, right, required to form blood clots. So a lot of your anticoagulants like heparin, sodium citrate, EDTA, all these anticoagulants work by binding up calcium. And if you bind up calcium, the blood can't clot. So very effective. So phase 2, that prothrombin activator that we just saw at the bottom of the last slide, that causes prothrombin to be converted into thrombin. And thrombin takes fibrinogen, that's a soluble protein in the blood, and causes it to become insoluble. And that makes a polymer. They link together. They snap together and form these long strands that make the fibrin mesh. This factor 13 is called fibrin stabilizing factor, and that's what makes the fibrin strands get longer. And you can see here another place where calcium is involved in the process too. So there's a look at scanning electron micrograph of erythrocytes, red blood cells that become trapped in this net, this fibrin mesh. Isn't that cool? Okay, then after the clot's formed, it stabilizes. And the actin and myosin protein filaments that are in the platelets contract within 30 to 60 minutes. And contraction pulls on the fibrin strands, squeezing the serum from the clot. And this helps to draw the ruptured blood vessel edges together. Now, factors that prevent undesirable clotting, platelet adhesion is prevented by the smooth endothelium of blood vessels that prevents the platelets from clinging. So the endothelium is actually simple squamous epithelium, but it's very smooth, so things won't stick to it. Antithrombic substances like nitric oxide and prostacyclin secreted by endothelial cells will also minimize the effects of thrombin in areas distant from the injury site. And then vitamin E, quinine, acts as a potent anticoagulant. Here's some other anticoagulant drugs. Aspirin is an antiprostaglandin that inhibits thromboxane A2. Heparin is an anticoagulant used clinically for pre- and post-operative cardiac care, and that binds up calcium. And warfarin or Coumadin is used for those prone to atrial fibrillation and also prone to strokes and producing blood clots. That interferes with the action of vitamin K. Remember, vitamin K is needed to produce 4 of those procoagulants. So without vitamin K, you can't make those, and so you essentially can't complete that coagulation cascade. Thromboembolic conditions. A thrombus is a clot that develops and persists in an unbroken blood vessel and may block circulation, leading to tissue death. An embolus is a freely floating blood clot or a thrombus that's in the circulation. And an embolism is where the embolus gets to a blood vessel that's very small and causes an obstruction. And you can have this in the pulmonary circulation. You can have it in the brain, cerebral emboli that result in a stroke, myocardial infarction in the coronary circulation. And the risk factors for thromboembolic conditions are atherosclerosis, building up plaque on the interior walls of blood vessels, inflammation, slowly flowing blood or blood stasis from immobility. Thrombocytopenia is a deficient number of circulating platelets. And sometimes people will present with petechiae. These are little pinpoint red spots on the skin which appear due to spontaneous widespread hemorrhage. And sometimes bleeding disorders are caused by suppression or destruction of red marrow, by radiation, a malignancy, or certain types of drugs. And a platelet count less than 50,000 per microliter is of diagnostic value. And you can treat with transfusion of concentrated platelets. Because the liver is important in producing proteins and these procoagulants, if you have impaired liver function, you don't have the ability to synthesize these procoagulants. And other causes can be vitamin K deficiency, hepatitis, which is a liver disease, and also cirrhosis of the liver. Impaired fat absorption, because vitamin K is fat soluble, that can cause a problem with absorbing this vitamin so that it can be used by the liver. And liver disease can also produce the liver from producing bile, which impairs fat digestion, because bile is an emulsifier of fat, and vitamin K absorption. Hemophilias. Hemophilias are bleeding disorders of genetic disorders that are inherited. Hemophilia A is the most common type, representing 77% of all cases, where factor VIII is the deficiency. Hemophilia B, factor IX is the deficiency, and hemophilia C, milder type, with factor XI being the deficient procoagulant. Symptoms of hemophilia include prolonged bleeding, especially in the joint cavities, and you treat with plasma transfusions and injection of missing factors. So those are bleeding disorders, and that finishes up the chapter.